great pleasure to be here, and I'm hugely grateful to Philip Kennedy of the NYU Abu Dhabi Institute and to Vice Chancellor Al Bloom and Provost Fabio Piano of NYU Abu Dhabi for great hospitality these last couple of days. It's been a really, really special time for us that included both a conference. I really enjoyed meeting some of the NYU Abu Dhabi undergraduates last night and talk about some of these issues and about law. And all in all, it was spectacular 2 days. So this lecture will be a combination of two things. So we're going to try to bring to you some of the salient arguments in the book that Michael and I wrote that was published a couple of years ago, and of the conference that we've been having for the last 2 days, where we got together a leading group of academics from around the world, I think every continent except Antarctica, where this issue doesn't seem to be practiced very much, and to discuss the expansion of cost-benefit analysis into the global scene. So I'm going to start in a somewhat parochial way. I'll sort of start with kind of my own intellectual history of engagement with this issue, and I'll give you a very brief thumbnail of the history of the development of this issue in the United States, and then eventually we'll sort of work our way onto how it came to expand into the world, what issues we face in the United States, what issues are faced elsewhere, and where this is all likely to go next. So the modern history of cost-benefit analysis in the United States as a significant tool for evaluating public policies dates back to the election of Ronald Reagan as president in 1980. I say the modern history because there are lots of precursors, and I learned at the conference that apparently Thomas Jefferson had something significant to say about this topic. But nonetheless, this is the modern history. And Ronald Reagan, after he became president, I think in his second week in office, he issued an executive order. And this executive order required federal agencies to perform a cost-benefit analysis that is on federal regulations that were expected to have an impact on the U.S. economy of $100 million or more. So any major federal regulation would have to be accompanied by a cost-benefit analysis, and by its terms, the executive order provided that with some small exceptions, the regulation could not be adopted unless the benefits of the regulation exceeded its costs. We'll come back in a little while to talking about how one measures these things and so on. So that was an important move. And there was a second important move that was made, which is that the job of overseeing compliance with this executive order was given to a new agency that had very recently been created. Very obscure agency has become very powerful. It's called the Office of Information and Regulatory Affairs, and is part of the Office of Management and Budget. So agencies would now have to perform these cost-benefit analyses when they promulgated regulations. The rule and the associated cost-benefit analysis would have to be sent over to this group, this OIRA, the Office of Information and Regulatory Affairs, which would review the cost-benefit analysis and determine whether it was consistent with what the president had required in his executive order. And if not, that began kind of a back and forth between OIRA and the agency that was trying to promulgate the regulations. And usually these things were worked out in the process, and every once in a while they became more salient, and there was a tiebreaker mechanism in the Reagan administration. This issue was sent up to the vice president, George H.W. Bush, who then figured out what to do about it. And that only happened a small number of times. Usually it was worked out at an earlier time. Now, there was a question as to what would happen with his executive order at the end of the 12 years of Republican administrations that started with the election of President Reagan. And it was a reasonable question to have because his executive order grew out of the 1980 election, where Ronald Reagan ran on an anti-regulatory platform. He argued that regulations were imposing too many costs on the U.S. economy, and the result of this was negative, and that the sort of economic sluggishness of the period could be attributed in some way to too much and too stringent regulation. But what was interesting is when Bill Clinton was elected president in 1992, within 6 months of becoming president, he issued a new executive order. But what was interesting is the new executive order was very similar to the Reagan order. There were some salient differences, but they were really differences of tone and not differences in terms of the two main elements of the executive order. That is, a requirement that major regulations be accompanied by cost-benefit analysis, and that OIRA, this separate office, be charged with reviewing these cost-benefit analyses to make sure that they met the requirements of the executive order. So that remained in place in the Clinton administration, and when George W. Bush was elected president, he operated for the first 6 years of his presidency under the Clinton order. For the last 2 years, he issued an additional order that extended the requirement beyond regulations into other forms of administrative action called guidance documents and so on. But the bulk of the procedure was the Clinton procedure. And when Barack Obama became president, he's so far, almost 2 years into his administration, has kept the Clinton executive order in place. And while he repealed the Bush order that I just told you about, he indicated as a matter of policy he would continue essentially doing what the Bush order indicated. So why did I tell you this story? Well, there's a reason, which is that what seemed like a controversial move early in the Reagan administration has become institutionalized. We're about to celebrate, I don't know what we'll do for the celebration, but we're about to celebrate 30 years of this process. And it now, I think it's fair to say, it has bipartisan support, and it is quite likely to persist way into the future. Nonetheless, it is quite controversial. Progressive groups, environmental groups, groups that want sort of greater protection of health and safety have typically been opposed to the use of cost-benefit analysis, and I'll come back to that question in a few minutes. Now, why has this procedure become so institutionalized? And I think there are two important reasons. One is that most environmental problems have a certain structure that makes cost-benefit analysis seem like a quite compelling methodology. In the United States, when we talk about environmental issues, we're primarily talking about public health. We're primarily talking about reducing concentrations of pollutants in the ambient air, in the water, and so on. I'll focus on the air. And the main benefit of reducing those concentrations of pollutants is that fewer people will die. And for some of these pollutants, a lot fewer people will die. There are sort of great public health benefits. It's not that we don't care about the protection of endangered species, natural habitats, and so on, we do. But the bulk of environmental law in the United States is focused on public health, and this is not true just in the United States. I mean, the proceedings of this conference showed how countries elsewhere in the world are grappling with exactly the same problems. So what is the fact that a great deal of environmental regulation is supposed to protect public health have to do with the prevalence of cost-benefit analysis? And it's the following. Back in 1970, which is kind of the modern beginning of U.S. environmental law, there was a view that was, I don't know how widely shared it was, but it certainly, did I do this? Okay, sorry, I don't know what I did, so I can't undo it now. I guess the problem would correct itself in 30 seconds. Sorry about that. So there was this view in 1970 that many environmental problems had what are known as thresholds, that there were levels below which there would be no adverse health consequences. And so being kind of below the threshold became a salient focal point. So obviously, if you could be below the threshold, you would try to do that, and then there'd be sort of no adverse consequences. The centerpiece of our clean air legislation, which dates back to 1970, are standards called National Ambient Air Quality Standards, and they're designed to be set to protect the most sensitive population in the country against the adverse health effect that gets manifested at the lowest concentration. So the idea here is that if you sort of find the most sensitive population and you protect them against the health effect that they first perceive at the lowest concentration, you'll be protecting everyone against all health effects, and we'll be like really happy. It'll be a really good state of affairs. And if we can achieve that, then maybe we should try to do that. I mean, maybe it can't be achieved, maybe it costs too much and so on, but if we can achieve it, that would be a good thing to try to do. I think we learned quite quickly that most pollutants don't have thresholds. So even though we established a regulatory structure based on thresholds, I think we learned quite quickly that most pollutants don't have thresholds. And most significantly, a very important class of pollutants, carcinogens, pollutants that cause cancer, are widely believed not to have thresholds, which means that they have adverse health effects at every concentration. Now, obviously, the higher the concentration, the worse the adverse health effect. But the only way to have zero adverse health effects is to go down to a concentration of 0. And we don't want to do that. Why don't we want to do that? Because it's not really possible to have industrial activity without tolerating some level of pollution. And so in a celebrated concurrence for the U.S. Supreme Court, Justice Breyer, who's a serious student of the regulatory state, indicated, half jokingly, I think, maybe half seriously, that in the Stone Age, people had low life expectancies. So the consequences of not having an industrial society as we know it, was being in the Stone Age, and that would not be good even if all we cared about was public health, because people didn't live very long then. So we can't have an adverse, sort of a level of permissible adverse health effects that goes down to 0. We have to pick some other number, some number higher than 0. And so that picking a number higher than 0 essentially means deciding how many lives we're prepared to lose in 1 year, as a result of exposure to that pollutant. Typically, risk assessors construct curves. The curves on the y-axis have harm. On the x-axis, they have concentration. They sort of plot harm as a function of concentration. They can tell you for a single individual what's the probability that they will die during the course of that year as a result of exposure to that pollutant. You can then multiply that by the population affected by the pollutant, and you basically have a curve that tells you how many people are going to die in the population as a whole, in the affected population, as a result of the exposure to that pollutant. So then a decision maker has to figure out, well, what level do we want? We can't have 0. We already discussed that. But we can have a whole bunch of other levels. There's a whole continuum. And there's no really good answer to that question unless you know what the consequences on the other side are. That is, if the consequences are low, if the sort of pollution control costs are going to be low, if the dislocation of the economy is going to be low, we should want a lot of it. If the consequences are going to be high, we might want less of it. And the other point is that we might want a lot of protection for some pollutants and less protection for others. Why is that? Because it might be quite cheap to reduce the concentration of some pollutants and very expensive to reduce the concentration of other pollutants. So if we said, look, we can't really do this, it's just sort of too difficult to make those kinds of decisions, let's just decide that we won't tolerate the loss of more than 10 lives. I'm picking a number at random from exposure to any pollutant in the society. Someone's going to show up and say, look, you have 2 pollutants, you're prepared to lose 10 lives from exposure to each. Why not reduce the concentration of one pollutant from 10 to 1, which can be done very cheaply, and increase the concentration of the other pollutant from 10 to 15, which is going to save a lot of money because of the control costs. So now you'll have, instead of losing 20 lives, you lose 16 lives, 15 from one pollutant and 1 from the other, as opposed to 10 from each, and it's going to cost less. Why not do that? And once you decide that you want to do that, I think not doing that is irrational, you are sort of inexorably drawn into cost-benefit analysis. And And I think most presidents, all these presidents who've done this have come to understand that. They've also realized that the combination of cost-benefit analysis and control by an agency that's very close to the White House gave them certain control over administrative action they didn't otherwise have. So I think that is what accounts for the institutionalization of cost-benefit analysis as sort of an overarching method for evaluating government policies in the United States. Now, why the controversy? So I alluded to the controversy. And I was shocked when I first got exposed to this. So in the 1990s, late in the 1990s, I was on the Science Advisory Board of the Environmental Protection Agency. This is a group of outside experts that basically does peer reviews of policies and studies done by the Environmental Protection Agency. And in those days, the Environmental Protection Agency was doing its guidelines for the preparation of cost-benefit analysis. And under administrative procedure that applies to these groups in the United States, all our meetings had to be open to the public. So basically, when we met in Washington, every trade association representing polluters, the people representing the chemical manufacturers, the American Petroleum Institute, or the groups as various as the Halogenated Solvents Industry Alliance, the American Water Works Association, all of these trade associations came to testify before us. Very professional testimony, very well represented by significant law firms. On the other side, no environmental group ever showed up to talk to us. None of them. And they had a lot of stake in this because we were deciding things like the value of a human life that was going to be used for the cost-benefit analyses. So one day I ran into a friend of mine who was the number 2 person in one of the major environmental groups. And I said, look, we're doing all this stuff and it sort of seems silly to me that you guys aren't actually coming. Why is that? And he says, you're right, but we just can't do it. Our members are too opposed, be too controversial, so we just can't do it. And a few years later, I was presenting a paper at the American Enterprise Institute, which is a conservative think tank in Washington. And I was talking about this, and one of the people in the audience was someone, Sally Katzen, who in the Clinton administration had been the head of OIRA, of the agency I told you about that does these reviews of cost-benefit analysis. And she raised her hand and said, that was exactly my experience as the OIRA administrator. I tried to engage the interest groups in discussions about this. The industry groups were delighted to come. They would have come to my office every single day if I had invited them every day. I just invited them sometimes. No environmental group would ever come, and she said, eventually I just gave up. So that was shocking to me because the group I was in was sort of a backwater of the government. It was basically as unimportant a position you could have where you got some piece of paper that said you were appointed by the government. But her position was actually really important. I mean, my thing was a kind of part-time thing. I did 3 days a year. This was probably the most important full-time job in the regulatory world. And that they wouldn't talk to her. So why is that? I guess it goes back to the history I was telling you about. Cost-benefit analysis in the United States has this sort of anti-regulatory beginning connected to the election of Ronald Reagan. And these groups have never sort of overcome the initial suspicion that they had. Now, one of the reasons that Mike and I wrote our book was to try to channel progressive groups out of this debate about whether cost-benefit analysis should or should not be used for regulatory purposes, because it's a losing battle for them. That decision has been made, and it's already been made decades ago. And instead, we want to channel them to an area where I think they could do a lot of good, which is in a discussion of the methodologies for valuing costs and primarily valuing benefits. And our book argues that as a result of the fact that one side of the political spectrum has absented themselves from this debate, important methodological fallacies have resulted in the use of cost-benefit analysis. And I'll give you an example. So I know that this will come as a shock, but in order to be able to do cost-benefit analysis of health regulation, you have to determine how to value a human life. And in the lingo of this kind of work, there is a concept called VSL, which is the value of a statistical life. It's not what someone would pay not to die or not to be killed. Instead, for the most part, these values are derived from workplace studies, where workers take jobs that are somewhat riskier than other jobs. So, for example, some workers decide to take jobs driving trucks instead of doing something else they could do with their level of sort of education and skills, and presumably they get compensated for this higher risk. And presumably there's a probability of death coming from that. It's not enormous, but it's not trivial. And from the wage premium that is used to compensate people for a certain probability of death, a value of statistical life is derived. So if people get sort of compensated $100 for an extra 1 in 10,000 probability of dying over the course of the year, you would divide the $100 by 1 in 10,000, and you would come up with a value of statistical life of $1 million, which is actually low in the U.S. It's sort of a simple example. The numbers that are used from these studies are around $7 million. So here's a fallacy that we focus on. There's been a move among some of these anti-regulatory figures that I was telling you about to say, look, these workplace studies of truck drivers are studies of 40-year-olds with a 40-year life expectancy, but some environmental programs are going to benefit 70-year-olds with a 10-year life expectancy, so we should prorate the value of statistical life by the remaining years of life, and so you'll get a quarter of the value for environmental programs that are supposed to help 70-year-olds. It turns out that there is no support in economic theory for doing that. That is, most people value scarcer things more than they value less scarce things. And also, the extent there are empirical studies of this, they show sort of pretty constant level from ages 40 to about 70, and then the values do begin to decline, but decline much less than they would if you use the proportional relationship. So that's one fallacy. We explore many in our book. So what we've been trying to do is to try to get the various interest groups to engage along these issues where a difference can be made, as opposed to engaging on issues that have essentially been decided. Now, I talked a lot about the U.S. I can tell you just in 1 minute, the European Union has followed essentially a similar path. Came a little later, but in some sense, their cost-benefit requirements are broader than those in the United States. Ours apply only to government regulation. They don't apply to legislation. In the European Union, there are requirements that apply to legislation as well. Now, we're now this conference is really about extrapolating beyond the experience of the United States and the European Union to other countries, both at sort of every stage of development. And various interesting things have come up. I mean, first, my view is that there's huge benefit to using cost-benefit analysis as a way of justifying desirable regulation in countries that are just beginning to set up a regulatory structure. And the reason is that in a country that has not done much regulation, it's almost always going to be the case that the first round of regulation is going to have is going to look very attractive on cost-benefit grounds, because typically the first pollution reductions are the cheapest to do. So it's very cheap to sort of eliminate the first 10% of pollution. It's very expensive to eliminate the last 10% of pollution. So if you've already been doing this for a long time, you already eliminated the first 90%, you're really down to the last 10%, and that's very expensive. But you haven't done much, then there's sort of great benefits. And so the use of cost-benefit analysis would provide us a very strong justification for getting sort of a start in the regulatory process. Also, it's a norm that promotes transparency. One thing one worries about whenever government acts is it will act in inconsistent ways. it will take some problems seriously and not take another problem seriously, maybe because there are powerful groups that care about one problem and don't care about the other. Cost-benefit analysis provides a way to add structure to the discussion, and it allows citizens to be able to evaluate the reasons that are given in support of regulation. Now, there are all kinds of problems when one tries to move from the United States and the European experience to other countries. So one problem is there are basically very few studies in other countries, and there are probably problems in conducting studies. And also, some of these studies take a long time to conduct, and if one wants to sort of get this process started, one might not want to wait that long. So there's a whole whole academic methodologies that look at how one can extrapolate from values obtained in some countries to use them in others. And in the sort of language of this kind of work, these are benefit transfer studies. So for example, we know what the value of statistical life in the United States is. There's a fair amount of convergence around that question. But how does one apply that value to a country that might have a very different per capita GNP? Because most people understand that these values are highly contingent and highly dependent on the sort of economic standard of the population. Well, there are techniques for doing that, and that's one of the things we discussed during our conference. Especially in developing countries that don't have a mature policy-making structure, a lot of government action focuses on the evaluation of individual projects. In the US, more of our focus is on sort of overarching government policies. Now, cost-benefit analysis can obviously play a very important role in evaluating projects. You know, sometimes projects that look good from the perspective of the private enterprise that wants to undertake the project, and that is there are profits to be made, look bad when one looks at broader social consequences. So in order to make this project, we have to clear a rainforest. Clearing the rainforest is going to have bad consequences for local population, but it'll have bad consequences for climate change, which is a global problem. So, so there's going to be much more focus in developing countries on the evaluation of individual projects. But the conclusion that I want to leave you with is the following, is we've detected, and certainly this conference confirmed, sort of a much greater level of interest around the world to evaluate social policies through the use of cost-benefit analysis. And we believe, I mean, this is work that Mike and I have done, that this is actually a very good development. There are enormous problems at the next stage of how to implement that. I already indicated in the US, we've been doing this for 30 years, we still have a lot of valuation issues that are very highly contested. And certain methodologies that we take to be erroneous have become somewhat entrenched in the regulatory process. And hopefully will, this sort of discussion will lead to a better, will lead us to a better place. But the issues become compounded when we have to think about how to move beyond the experience of a particular jurisdiction that has had 30 years of experience with this at a high level into countries that are quickly trying to move into having a rational system for policy making and for project evaluation. And that was basically what we spent a lot of time talking about at the conference. And it's very encouraging to see the interest that there is on the part of colleagues around the world to focus on these matters. So I'll stop here. I'm delighted to try to answer any questions that might come up when we get to the Q&A period a little later on. And thank you very much for coming tonight.
Thanks very much, Ricky, for your thoughts. I'd like to invite Oliver Harrison to join us on the podium today, right now. He is the Director of Public Health and Policy at the Health Authority Abu Dhabi, where he has been since 2006. He built the agency's public health department to assess and address Abu Dhabi's public health challenges in a variety of different areas, focusing on diabetes, cardiovascular disease, cancer, road injury, and other areas. He currently leads the Abu Dhabi Health Research Council and heads the Health Authority Departments of Drugs and Medical Devices, Policies and Standards, and the Zayed Complex. Prior to joining the Health Authority, Oliver spent 5 years with McKinsey's healthcare practice. He's a medical doctor, foundation scholar in medicine and neuroscience at Cambridge University, an honorary lecturer at Imperial College, and a principal investigator at the Abu Dhabi Partnership with Johns Hopkins School of Public Health. Thanks very much for joining us today, Oliver, and we look forward to your thoughts.
It's nice to meet you. Nice to meet you too.
Great. Well, thank you very much for the introduction. It's great to be here. It's for somebody that's been in Abu Dhabi for 4 years, as I have, it's extremely impressive to see every year such a substantial increase in the capability and the capacity of the Emirates overall, but specifically in health and academia. It's wonderful to have heard just the last 15 minutes of the previous speech, and I can feel that the quality of discourse regarding some of the challenges and some of the opportunities facing this very unusual but very exciting emirate improves substantially year by year. So what I would like to talk to you about, I guess, is almost a response to the comments that I heard, which is really a very sharp, thank you, Abu Dhabi focus. And what I'd like to talk about is how we use economics in shaping public health policy, and to talk, first of all, a little bit about Abu Dhabi in terms of context. A very brief presentation, but... Okay, so first of all, talk about Abu Dhabi context, challenges and opportunities, and then talk about how we tackle cardiovascular disease. And I think what you'll see quite quickly is that some of the benefits of working in a country, in an emirate, which has very little institutional inertia, has a relatively small circumscribed population, has a very strategically minded government, takes us to a place where we can actually start to drive innovation, global innovation. And that's something that we can certainly do in healthcare, we're beginning to do in healthcare, and in some of the other verticals within government as well. And then I want to touch on Michael Porter and Elizabeth Treesberg's book from 2006 called Redefining Healthcare, and some of the challenges they set the industry, which the US health system has really struggled with for a number of reasons, which I'll touch on, but which we're going great guns in addressing here in the Emirate of Abu Dhabi. And then I'll touch for a broadly academic community and some areas for research going forward. So first of all, for those of you newish to Abu Dhabi, so newer than my 4 years, welcome to Abu Dhabi. This is a very exciting and dynamic part of the world, and a very exciting and dynamic and very unusual emirate within a very exciting part of the world. So from a public health point of view, there are some really great reasons to come to work in Abu Dhabi. We have a relatively small population, 2.1 million people, give or take, around 20% Emirati and around 80% expatriate. We have a very highly strategic and focused government, which doesn't have some of the partisanship that, for example, we see in the United States. And much like a government in Singapore, sort of operates according to almost a corporate principle with a CEO and a team which is very aligned and delivery focused. We have, of course, a very unusual genetic portfolio in the population. The traditional Bedouin Khaliji Arab genotype is what's called a founder population. It's relatively pure breeding, to use the language, for about 30 to 40,000 years. There are one or two others, Eskimos, for example, certain Native American populations, which are also founder populations, but most other populations in the world by now have had quite a lot of interbreeding rather. But we also have, in the 80% expatriate community, representatives from more than 150 countries from around the world. A very substantial number from the Indian subcontinent, a large number from Europe and from North America, and we're all exposed to what can be described as a very unusual environment, both climatically, geographically, economically, and so on. So we have almost a controlled study emerging where we have the Arab genotype and these 150 other countries as well. Over the last 40 years, of course, there's been what can really be described as an extreme pace and depth of modernization. The health system here is relatively well resourced, and we've got world-class data systems. I'll come back to talk about that. So that presents some challenges for people like me, because there's nowhere really to run. There's no excuses, there's no one to blame, there's no particular challenge with doing public health that you don't see in other health systems. And really we have sky-high expectations from the community, the UAE citizens, of their government and their government's ability to deliver impact in public health and to meet some of the challenges that we see here. So we really aim to deliver domestic impact whilst also perhaps learning some lessons that can be applied elsewhere. So I'll come back to this diagram, but this touches on what we've been able to do in terms of integrating health data. Now, the United States and UK, lots of European countries have begun the journey of uniting health data, but in Abu Dhabi we've been able to tie together birth notifications, death notifications, screening of the population, so for visa screening for expatriates, different types of cardiovascular screening that we're using for the local population, with clinical episode data, so whenever anyone, national or non-national, visits a primary, secondary or tertiary care facility, government or non-government, on health insurance or not health insurance, all of that data is captured using the same unique identifiers. Now, that effectively means that Abu Dhabi is a cohort. So it's a cohort of 2.1 million people with this unusual genotype, exposed to some very unusual environmental factors, and I'll come on to talk about some of the phenotypic consequences. But essentially, this data is available for anyone to access according to our data standards and procedures at the Health Authority through a data access panel. The data is all collected and processed and shared in accordance with the standards of HIPAA, the Caldecott Principles, Nuremberg Code, Helsinki Protocol, Revesz International standards, but also, and therefore usable for FDA, for EMEA approvals, but also it's in compliance with Sharia law and UAE and Abu Dhabi federal and domestic law. So that's a little bit of context, first of all. And I'll now talk about tackling cardiovascular disease. So the world really is struggling for this. This is one reason why the world's really struggling to tackle cardiovascular disease. Now, this was a chart which I really like, which was created by the UK Future Choices project report in 2008. And it sets out just some of the causative relationships which result in obesity. And the reason I like this chart is it says two things. I mean, one, it looks like a plate of noodles, and as opposed to, let's say, the causative relationship of a mosquito carrying Anopheles mosquito carrying malaria, biting an individual and spreading an infectious disease, the etiology, the causes of chronic diseases, for example, obesity, which then has its health sequelae, are extremely complicated in that there are multiple. They are also what scientists and mathematicians call complex, in that there are numerous feedback loops that happen and interdependencies. Now, what that means is that much like the allegorical flap of a butterfly's wing in the Amazon that causes a tornado in Kansas, affecting one of these parameters here in the system can affect the overall state of the system. So these different sections here include hormonal factors, for example, educational factors, social factors, the impact of the health system, and various other pieces. But the point is that the causes of chronic diseases are not only complicated, they are also complex. And complex systems theory, complex systems analysis is something that we're really beginning to tackle and get our arms around in science and mathematics. So if we look at a classic model of complexity from nature, the honeybee, the individual insects, the individuals within a colony themselves are actually rather dumb. So they have a very small brain, a couple of hundred active neurons which are involved in cognitive processing. And yet, if you put a cluster of them together within a hive, you get lots of very interesting emergent behaviors. And those emergent behaviors include, for example, forming a honeycomb, but also foraging for food, being able to communicate with each other using these structured forms of communication. And if we take this paradigm and then apply it to a human society, the nature and type of conversation, of course, is far more complex, it's far richer, we have much more complex brains. Our forms of communication themselves are much more complex and rich, certainly for most people. But we do have these emergent patterns, which we call language and culture and media and various others. So if we can understand these underlying principles and how these systems work, then perhaps we can intervene in a good way. And some of you may be beginning to join up the fact that we've collected this kind of holistic data set with where I'm taking this. So if we take this individual, So we take this individual and he has a series of health choices to make. So health choice is not, do I see the doctor, do I see the nurse, do I visit the hospital? But the various choices that one makes over the course of one's life, which lead inexorably to a high risk, for example, obesity, or a low risk, for example, a normal weight. So these choices may be, well, what am I going to have for dinner tonight? What am I going to do with my weekend? Am I going to go and kick a ball around with my kids, or am I going to sit in the cinema or perhaps sit on the couch and treat myself? So the point is that nobody has eaten in history a single meal which has made them obese. Nobody has had such a lazy weekend that they've become fat. It's the behaviours that happen thousands and thousands of times, caused by these multiple loops of interaction, which lead over time, over tens of years, from one health status to another health status. So the question is, well, so what? Well, so in looking to tackle chronic diseases here in Abu Dhabi, we're aiming to do something really innovative. What I haven't mentioned is that we've known for a long time that the pattern of cardiovascular risk in the Gulf is extremely unusual and extremely stark and poses us a very big challenge. The 2005 International Diabetes Federation Diabetes Atlas ranked the UAE as the second highest prevalence in the world after the tiny South Pacific island of Nauru in terms of prevalence of type 2 diabetes. And this represents a major challenge because diabetes can cause an 8 to 10 year reduction in life expectancy. So at scale, with 20% of our population compared with benchmark figure of, say, 7 to 8% in the United States, at least 20% of this very young population suffering from diabetes today, the question is, well, what can we do? And unfortunately, looking around the world, we see that there aren't great examples of population-wide intervention programs that we can build on in chronic diseases. So we're having to think about this innovatively. And working with WHO, the World Economic Forum, International Diabetes Federation, American Heart Association, and others, we've distilled it down to two models. The first is screen, then plan, then act, and then screen, then plan, then act, and keep on doing this at the level of the individual. And the second is then an impact pyramid where we take actions at the level of the population. So, for example, like Tom Frieden in New York, we can ban trans fats, we can create mandatory food labeling, we can ban smoking in public places. At the other end, there are individual level interactions that we can create. So, for example, individuals seeing their physician, individuals taking a particular medication, individual education and counselling. And then in the middle, there are a whole slew of group actions that can be taken. And really, there are different meaningful groups that you could talk about in any society, any culture. We are a social species. So groups could be an employer. Let's benchmark NYU against Kustar, against MIST, and say, well, who's got the highest levels of obesity? And then let's incentivize the dean to do something about it. There may be groups of where people live. So we can look at Al Bateen area, Al Mushraf area, Al Ain, compared with the Abu Dhabi Island, and look at how those groups compare, and then give somebody the responsibility to do something about it. And also enable their interventions by saying, well, here's a menu of really great things that people have tried elsewhere that you might like to experiment with. So, for example, strip fatty foods, candy, chocolates out of the canteen and replace them with fruit and vegetables. Or perhaps you can educate your staff about regular exercise, provide them 30 minutes of downtime in the middle of the day to go and take a bit of a walk around and so on. But what we've done in the Wakaya program, beginning with the screening here, is we've screened 97% of adult Emiratis. It's a unique Framingham cohort. We screened them against the Framingham risk factors for cardiovascular disease, which have been elucidated from the Framingham study from Framingham, Massachusetts, and it began in 1948. It's one of the early NIH programs, and really elucidated the risk factors for cardiovascular disease that we know very well. So hypertension, tobacco smoking, cholesterol, diabetes, and so on. And we screened 97% of adult Emiratis. That's a Framingham cohort now of 190,000 people plus. In addition, we've got clear clinical standards we've developed with the Cochrane collaboration, UK groups, including the National Institute for Clinical Excellence, and we've created a website and call centre. Now, these have been designed with a view on cost of the intervention, cost effectiveness of the intervention, and we are also collecting the data, of course, so we can learn by doing. And then the actions involve the health sector and non-health sector, and there's a whole slew of interventions driven by health sector and other entities. So here in a nutshell, that's the good news. The bad news is what we found with the screening. And 70%, much like the United States, 70% of adults over the age of 18 are overweight or obese. 36% are obese and 34% are overweight. In fact, only 30% of adult Emiratis have a normal weight. 21% have an evidence of diabetes. This is a population with a median age of 30.2 years. It's an extremely young population to have such a high rate of diabetes. And those in their 50s and 60s have a prevalence of diabetes of more than 50%. So we know that as the population ages and the population pyramid shifts more towards older ages, that this prevalence will rise. And in fact, we predict that within 5 years, we'll begin knocking on the door of Nauru. We do conversely have relatively low levels of high blood pressure, and this is probably because the diabetes effect is mediated through genetics, and this very young population haven't yet developed the hypertension. So the initial conclusions are a very high rate of cardiovascular events. We know that at least 50% of these people don't know that they are sick and don't know that they have a need for treatment. So we predict from the Framingham predictive modelling around 9,000 cardiovascular events. Those are heart attacks and strokes, of which about half will be fatal over the next 10 years. So that's 4,500 deaths. And we do also know, good news again, that from the evidence base, that 70 to 90%, depending on how you look at it, of these events are preventable. So to put it another way, we have the opportunity to save 3,000 Emirati lives from this very young population and very precious population. But in addition to the challenges that we face, I think there are some unique opportunities. So alongside saving those lives, I think we have an opportunity to really render Abu Dhabi as a healthy environment and possibly one of the healthiest environments to live in the world. And we'll all have different ideas about what that might look like. We may have some cynicism or optimism that we can actually pull it off, but what a great opportunity for us to try to pull off. We can also drive really for historic impact through coordinating the activity, aligning the incentives of public, private and civil sector entities around achieving a shared goal. And in so doing, create unique knowledge and contribute to global health challenges and publish in the literature and do some really great things that perhaps US and European markets can also learn from. And at the same time, really build unique and distinctive opportunities for academic institutions, for the private sector, and really for all of society. So that really is the challenge and the opportunity. So specifically, we're aiming to do, this being Abu Dhabi, better than anyone's ever done before. I think Finland and North Korea have just published their 35-year impact data showing a 73% reduction in cardiovascular risk, so we're aiming for at least 74. And we have some specific targets for how that works. Now, I hope all of you have brought a pen or something you can use to write something down, because I'd like to show what this looks like for you, but I don't have time to actually demonstrate the website. So if you draw your pens now so you can write down the URL that's coming up in 2 slides' time. There are essentially 2 components for the Waqaya program in Abu Dhabi. Waqaya means protection or prevention in Arabic. We have the health sector response, which is about care standards and making sure that the doctor and the facilities are ready when the patients come to see them. And also we're driving compliance to make sure that people actively seek the care. And that can be simple things like SMS. We're building a variety of call center and other interventions to create a dialogue between the data that we've collected, the database that we've collected, and the society. And there are also, of course, very substantial roles for what we call health guardians. So these are the regulatory bodies, but also the industries responsible for nutrition, physical exercise, employers, schools, urban planning, local governments, and so on. So there are really substantial roles for many sectors. So in the health sector, as I say, we've got care standards and then a whole slew of forms of compliance. And what I would like you to write down and take a look at is a website that we've created, which looks a little bit like an internet banking account. And this, we've created an account, a secure username and PIN number protected password, a little like an ATM card, for every single Emirati that we've screened. And we've created a dummy account. So the URL is wakaya.ae here. And you can log on to our dummy account, which is username 4564564 and then password dummydata1. And what you'll see there is the individual risk factor scores that you had from your screening, with a green, amber, red facility, where you sit on the decile chart, and then an overall score. And the text here, this being the internet, the text here responds to the numbers, and it gives you a personalised report and some personalised advice for what you need to do. And then you click here right in the middle saying actions you can take, and it opens up a world of clinical facilities that you can engage with and non-clinical interventions, diet, exercise. And we've negotiated some very substantial discounts for Emiratis who are going through this program to begin with. So I touched on the fact there that this program to begin with is just looking at Emiratis for two reasons. One, we wanted to keep it tight to really start somewhere, but it can be scaled for a broader community, it can be scaled for other countries, it can be scaled and adapted for a wide range of markets. And in addition, of course, Emiratis tend to be here, or much more likely to be here, from birth to death, whereas we have quite a large itinerant population that mainly spend 2, 3, 4 years here, and that poses very important questions around cost effectiveness and the kind of impact that we can reasonably aim to deliver for expatriates. It's not to say that we've given up, we're not going to do anything at all. I believe very passionately that we should do something, but there are some interesting questions for us to ask. Health Guardians, we've got well underway with Urban Planning Council. We have a demonstration block, as we call it, which is next to the Cultural Centre in downtown Khalidiyah. And we're looking at urban form interventions, and we're monitoring using motion cameras the utilisation of these spaces for doing exercise for pedestrians. We're working with the Education Council to look at opening up schools, their gymnasiums and swimming pools in the evenings and at weekends, and particularly during the summer recess when it's very hot here. There aren't too many opportunities to do exercise, but these schools represent great assets we can use. We're also looking at various interventions in nutrition and occupational health programs as well. So, forgive me for talking very quickly and for flashing lots of slides in front of you, but I wanted to introduce you to what we're doing with cardiovascular disease. Now, just very briefly on redefining healthcare. So, I want to tee this up, not go through it in detail. So, Elizabeth Olmsted, Teesberg and Michael Porter wrote a book called Redefining Healthcare in 2006. For many people who are interested in health reform, it's one of the key texts. And one of the key topics in the text is about defining value in healthcare and then creating value-based competition according to results. So really aligning incentives around what society would attribute as value. And we heard that the statistical life has an attributed value in the United States. There's good consensus around that. In the United Kingdom, the National Institute of Clinical Excellence, that does lots of number crunching in this area, has a value for a quality adjusted life year. So we're able to use a similar kind of methodology here, but remember we've screened everybody and we've got all of the data for the entire population. So what does that mean? Well, we are, in a nutshell, talking about economics and public health policy, doing a number of things, 3 things which lead to 2 specific intervention areas, and I'll just outline those for you. So the first thing is we're able to measure health on a routine basis. So we can do that by structured screening programs, but also every time you see a physician, your diagnosis, your key test results, CPT-4 codes for what the physician did for you are all recorded in one place. And we can do some very, very interesting analysis, which I'll just touch on. We can then look at aligning value with health. So I mentioned that we can ask your dean to take an interest in your health and the health of your faculty, and the local government representatives also to take a responsibility. But we can do that by measuring the health and then aligning value actively between the health status and whichever incentive is most meaningful for that entity. And then we monitor independently. It's very important that we don't ask people to monitor themselves. It's important that we have an objective and independent monitoring system, and routinely. So we have longitudinal data based at the level of the individual that we can then aggregate at the level of the group and at the population. So we can identify empirically which interventions are working for real and which interventions are not working, and we can run with our wins and we can cut our losses. So it's a large-scaled model where we're delivering interventions and we can see what works and what's not working. So the two things I'm just going to literally just touch on are, one, the use of the data, and two, agency-based healthcare regulation. It's your life we are after. Conceptually, healthcare is very simple. We aim as an industry to improve length and/or quality of life. And disease impacts people in a number of different ways. Somebody who's healthy lives for a period of time, their quality of life over time perhaps maintained and then falls off, and then they die. A cold can be pretty miserable. Seems men are more affected than women, my wife tells me, but colds can be pretty miserable, but they don't last for very long. A cataract can cause an increasing level of disability, and then it can be treated. Diabetes both reduces length of life and also can substantially reduce quality of life. Whereas appendicitis really lasts for a very brief time, and it's very easy to, well, relatively easy within the suite of challenges to intervene. So what we've been able to do in Abu Dhabi is put all of this data into some very fancy mathematics, which enables us to do some really very cool stuff. So people who understand kind of data modeling in this area may know what a nonlinear state transition Markov model is. Other people may not. But this is what the outcome of it looks like. This is for a real individual, health status from, so let's lay out health status from here, to, over time. This is the probability matrix that comes out of the data analysis that we're able to do. Now you can see this long horizontal diagonal here, which says effectively, if you're at this status, you're most likely to still be at that status, or there's a high probability you're still going to be at that status. But there's the patterns that are beginning to emerge in here are the impact of one disease on another disease. So it's in the literature, but a tiny voice in the literature, for example, that people who have established coronary artery disease often have a number of prodromal, so anticipatory, upper respiratory tract infections or other health observations which can presage the cardiovascular event, so stroke or heart attack. And for reasons that we don't fully understand, there seems to be a big relationship between your health status today and what happens with you over a period of time, and then your health status somewhere down the track. And we're really beginning to understand some of this in a very probabilistic way. And there's a lot more to talk about with this, but I'll just touch on it here. We are already learning some very interesting lessons from the data, and this is real-world data. This is effectiveness data across an entire population as opposed to just in the laboratory. So the other challenge that I said I'd touch on very briefly is agency-based contracting. So what is that? Well, in markets, health markets like the United States, we have some very, very big beasts. And we have, for example, at least a dozen regulators. So we have the Joint Commission regulating facilities. We have various medical associations and medical boards regulating physicians, nursing associations and colleges managing nurses, and various professional bodies for pharmacists and psychologists and so on. But we also have the FDA regulating drugs and medical devices. We also have regulators of financial products, SEC and various others regulating companies. We have regulations from the American Institute of Architects for the building standards and equipment standards come from another regulator and so on. But we also, of course, have some very, very strong lobby groups, including, for example, pharmaceutical industry, the American various medical bodies representing physicians, and it's a very crowded space. And sometimes people push in the same direction, but all too often people are pushing in different directions. So we end up with this hodgepodge of malaligned incentives. So in Abu Dhabi, things are rather simpler. We have 33 big hospitals. We have around 120 primary care facilities. We have one regulator, and that is the health authority, my employer. So under one roof, we combine the regulation of facilities and clinicians and health insurance and financing. Of course, we don't regulate the patients, the customers. They regulate themselves, and they tell us what to do. But we, under one roof, can tie lots of these things together. So we've responded to that opportunity by doing something quite unusual, which is to radically simplify the regulation of healthcare. And if you look at what's happened over the course of the year in the United States, some claim it as a success, some say it's a disaster in the reform of the health system. we see a document which is, I think, more than 3,000 pages generated by Congress, which sits already on more than 33,000 pages of primary legislation regarding the regulation of healthcare. Now, I'm not sure if anyone here can imagine what 33,000 pages looks like, but it's rather dense and complicated. And what's very likely is that there are contradictions, there are overlaps and duplications, and it obscures and obfuscates the key principles of what we're really trying to do with healthcare. So we've cut through that with a bit of a knife, and we've reduced it to around 250 to 300 pages. And we've created policy manuals, which are rather high level, but they cover everything, the full regulation of the facility, the professional, the insurer, and the regulator. So both the standing responsibilities of these entities within a system, but also the key interfaces between the regulator and the facility, the regulator and the professional and the facility, and so on. And just with these 4 manuals, it's what's called an agency-based regulatory structure, because we've regulated each agent, each of 4 types of agent within the system. We've been able to greatly simplify what we've done. We've also got a patient's charter that says for individuals what their rights and responsibilities are. But the point is, the test we set ourselves was that at least at some level, a physician who's flying into Abu Dhabi for the first time is able to read one book, 50 or 60 pages long, that specifies everything that they need to know. It references multiple other documents, which we call standards, but the policies stay the same. For the 3 to 5 year time frame, these should stay the same. But just in one place, you can find everything that you should be doing as a physician or as a clinician working within the system. Likewise, if you're a new CEO for a health facility, here's your list of things that you need to do and things that you need to think about. And here are your interfaces with professionals who you may hire to work in your facility, insurers from whom you're going to be claiming reimbursement, and the regulator. So by tying all of these together, we built a flexible system which is adaptive to the environment, but equally we create a system which is very clear, very simple, puts in one place what each of the stakeholders needs to know. And in so doing, we aim to create the alignment between those stakeholders. Now, we have already begun to think about how we monitor the impact at a system level of this intervention, both in terms of effectiveness and cost effectiveness of each individual policy, but also the overall system's approach to regulation. But we'd very much welcome your thoughts and ideas. So I mentioned the data before. I won't go back to it, just in the interest of time. But areas of research. So many of you may be thinking, well, this all sounds maybe a bit wacky, a bit strange, but some of it sounds like it might be quite interesting. I just want to touch on 4 areas of potential research. The first is what you could call orthodox public health. So we certainly have not performed many clinical trials here in the MENA region, Middle East and North Africa region. Only 0.3% of clinical trials patients over the past decade were actually from this region. But the MENA region collectively is between 350 and 370 million people, so pro rata we ought to be performing between 3 and 4%. Point is, many of the trials that we're using to make decisions about how to treat the Arab population are based on trials that were performed in the United States or in Asia or in Europe. And people are, of course, more similar than they are different, but there may be some key differences, as we see, for example, with African Americans compared with Caucasian Americans, and the best medications to use to treat for diabetes or for hypertension. We desperately need to do trials of clinical effectiveness and clinical trials here in Abu Dhabi. Equally, there are some orthodox things we can do with epidemiology and biostats, cost effectiveness, cost benefit and cost utility studies, and routine monitoring and evaluation to drive continuous improvement. I'll touch on the clinical research. We also have a desperate need to understand behaviours and what drives behaviours. So what makes me eat a little bit too much may be different to what makes somebody from Abu Dhabi eat a little bit too much, which may be different in turn to people from the Indian subcontinent. So we need to understand these behaviours, and I understand from speaking to a number of your faculty and also from LitSearch that NYU has a deep and enduring interest in this area of sociology and medical anthropology, and this really seems like an area where you can excel. So what's driving consumer behaviours? We have to bear in mind that products often meet psychological, not physiological needs in the 21st century, and we need to understand psychodynamics and the motivations behind people. And then to tie that together within this Wakaya framework, if you remember back to the bees in their hive, to tie that understanding back very pragmatically through the structure that we've created to focus the interventions on those who need them most, and to learn learn by doing from this real-world evidence that we'll collect along the way. There's a lot of very interesting discussion at the moment about how to use mobile phones, portable computers, the internet, and various other interventions. I do hope you'll log on to the wakaya.ae and keep looking at that. I think you'll find it quite interesting. So I'll just touch on one final thing before totally overrunning. The Wakaya program that we've created cost about $15 per head for screening. The total cost of Wakaya to date for each citizen in Abu Dhabi is about $15. And for that, you get all of this. Now, all of this includes some history examination and blood investigations. Now, if you're working, for example, in sub-Saharan Africa, and all you can do is the stuff in green, so you can ask history, you can measure somebody's height and weight, all you have is a tape measure and a notebook. And you can do that through a non-physician, non-nursing staff, then you can do this actually very, very cheaply. Now, what if you, also, if you're working the other end in a Wall Street bank, some of them, I think, still got some money, but if you've got $1,000 or $10,000 to spend, you may be able to do an MRI scan, or you may be able to do some interesting genetic testing, you may be able to do certain other things. But the point is that at some level, if you can get these data standards to be aligned, then actually you can put all of this stuff in one place. So you can put data from a $1 screening program, a $15 screening program, or a $10,000 screening program all on the same database. And then just imagine some of the lessons we could begin to learn from what works and what doesn't work in different parts of the world. So on that, I shall finish. And again, I'm very happy to answer any questions you've got in the Q&A at the end. But thank you for your attention.
Should we just, we'll just call on questions, and you can let us know whether you want both of us to answer them or only one, and decide who you want to answer the question. And I believe there are microphones around. Yeah.
I asked this question with an apology. I'm not an expert. I'm a sociologist. So the question is very general, and the question is addressed to the dean. Now, when you talk about cost-benefit analysis, could you tell us in very simple terms that we can understand what would be the fundamental difference if we move from a private company making cost-benefit analysis to a situation where public good is involved? How do you do that? What is the jump? What is the paradigm shift?
Sure. A public company is a great question. A public company making its own business decision, which companies do all the time, would typically not look at what we call the externality, sort of the cost that's imposed on society that the company doesn't see itself. Let me give you a simple example. A company produces steel. In order to make steel, it needs iron, it needs labor, it needs electricity. And a company, if it's successful, will optimize the use of these inputs. And as one becomes more expensive, as relative prices change, it will substitute from one input to another. But in order to produce this steel, the company also needs to consume clean air. There's clean air outside of this factory. Now there's a stack. And in order to produce the steel, clean air is going to get consumed. In the absence of regulation, the company won't see the cost of the clean air. That is, it will not have to pay for the clean air in the market. So what will it do? It will overconsume clean air. It will consume more of that than is socially optimal. On the other hand, if you show the company the price of the clean air, which would be the harm that the lack of clean air imposes on the people who have to breathe it, then the company would change its production mix. It might use more labor and whatever. It would invest more in pollution control equipment. It will sort of change its mix in order to have to produce the product in the optimal way. And what social cost-benefit analysis does is it looks at the externality, the costs that the private producer in this example doesn't see. And the sort of lack of clean air now translates into a certain number of deaths, into a certain number of years of, into a certain number of sort of hospital visits, into certain levels of morbidity, in a host of other consequences. And, but as I indicated earlier, we have to tolerate some of it. We don't have to tolerate all of it. No one would think that we should not internalize externality at all. And what cost-benefit analysis does is it tells us It gives us a structured way for evaluating the costs and benefits of reducing the harm. Yeah.
I just have a few questions about the presentation that we just saw. There was a point that you said that the health data was compiled in compliance with Sharia law, and I wasn't very clear on what that meant. I was wondering if the value of a statistical life has been calculated in Abu Dhabi, and how much that is. Your presentation, you referred a lot to the States and to the comparison. You made a lot of comparisons with the American health system. So were any other health systems considered, and why the focus on the American system? And finally, there was a point that you said about clinical research and that we should be encouraging things like that. Shouldn't this be qualified with the thought that we actually need to have regulation in place before we can take a step as serious as encouraging any sort of clinical trials?
Sure. So 4 very good questions. I'll try to address them all. So the first, in terms of Sharia compliance, we have, throughout the drafting of all of our policies and standards, including those around data capture, consent, the use of that data for societal and individual benefit, we've been consulting very closely with Sharia judges and experts in Abu Dhabi. Now, one of the upshots of that is that there are surprisingly few, but some fundamental differences between the point of view on some of these issues in Abu Dhabi, in our form of legislation, compared with legislation in the United States, for example. Now, let me change my comparator. So, in the United Kingdom, for example, the point here is that I'm no expert on Sharia, so I'm only going to talk in generalities. But there is an understanding of community benefit and benefit to people as a group, which is considered to be very important under Sharia law. The libertarian movement, the legal structures under Roman law, which underpins much of Anglo-Saxon law, tends to focus really on the rights of the individual. So there are a number of nuances that have shifted in the creation of our approaches, but which are enshrined in the policy and standards documentation, which are touched by that. And I'll be very happy when they're finally signed off and approved in their final version. To give you a couple of specific examples, I just want to make sure that they've been presented and signed off at the highest levels. So I'll jump to question 4, which is about the regulation of clinical trials. So one of the first things that we took a look at was the conduct of clinical trials and how we would go about regulating that. Now, there are some very clear international standards. So, for example, the Nuremberg Code, the Helsinki Protocols, and other standing agreements at United Nations and WHO undertakings regarding clinical research, which give us a lot of guidance with regards to the rights of the individual to opt in or opt out of research, the rights of the individual to see the benefit of the research, the rights of individuals to make informed decisions and to express agency. In addition, there are also standards regarding the admissibility of data for approval of new drugs from the FDA in the US or EMA in Europe. So regulatory bodies set a very high bar regarding human rights, regarding data transparency, regarding reproducibility and various other topics. And in addition, to publish in the literature, of course, there are a whole slew of other standards which are required to be met. And then finally, institutional IRBs, ethics committees, the peer review committees that are making decisions about go or no-go for individual research also have a slew of decisions to make. We have met the very highest standards internationally in the regulation of clinical trials and human subjects research in Abu Dhabi. And again, we've made sure that our starting point is federal UAE law and Abu Dhabi law, and we've also gone through the check of Sharia compliance. So in targeting that very difficult issue, we've made sure that we've checked all the boxes. Now, what that 3 years of labour means is that if we can now comply with the standards and policies that we've set here in Abu Dhabi, that the data can be used openly. It can be used for publications or for clinical trials, which will then contribute to the licensing of products. I think the second question you asked was about has Abu Dhabi put a value on the statistical life? The answer is, to my knowledge, no. Money's really important in healthcare anywhere. If you're not looking at cost effectiveness, not only are you one day going to end up spending a lot more money than you think you're going to spend on healthcare, but equally there's a lot of evidence that efficient use of funds, efficient use of resources, be that dollars, be that people, be that whichever, leads to better quality and better outcomes within facilities anyway. And there's a lot of really interesting data to support that. I forget your third question was about a US comparison compared with others. So forgive me, I was a little naive. I thought I was talking to a majority American audience here, it being New York University. I'm probably wrong. We did look at lots of other health systems, both in terms of designing the health systems reform in Abu Dhabi. So we looked, for example, at Singapore very closely. We looked at several of the European systems. The system that we have in Abu Dhabi is actually called a Bismarckian system. It's actually based on the German sort of health model with separate and independent regulator, payer and operators, clinical operators. It's not really based on the US model at all. So one notable difference is that we have mandatory social health insurance for everybody. That's for expatriates and also for citizens, so nobody's left uninsured. But there are numerous examples where the system here in Abu Dhabi markedly differs from the US system. And for that matter, it doesn't look 100% like any single health system. It's actually a mosaic of elements from different health systems. It's something which is unique to Abu Dhabi.
Yeah.
Another question, Dr. Harrison. I'm very interested to know about if there is a standard public health policy formulation process. You mentioned, and of course, where does cost-benefit analysis fit in the process? You mentioned something on evidence-based approach, but I was wondering, is there anything on a participatory-based approach? And if there is, could you give us specific examples on community engagement? And if you could specify because continuation to the answer you just answered, if you could use the example of how the decision was made to use this unique German-style model versus using anything else. I mean, how did we move from what we had in the past to the insurance, what we were referring to as an insurance-based model in general? Thank you.
Yeah, so...
sorry, just another small question on how was everyone screened? Because I'm just, like, we were asking each other, did you guys get screened? Did you guys get screened? So we were wondering, when did that happen? And did we all get screened and didn't know it? Or what was
So, yeah, screened in your sleep. But Bismarck said something in the 18th century, 19th century, said there are two things you should never look at being made in public. One is a sausage, and the other is public policy. The fact is that public policy is, I think, there are different ways of looking at it. There's Bardak, of course, laid out 8 steps, which classically you take in sequence to look at creating a public policy, a health policy, and it begins with framing the question, then assemble some evidence, you lay out some options, you prioritize with a grid, you put some weightings behind it, make a decision, syndicate with stakeholders, and then articulate and drive for implementation. Now, the reality for anyone working in Washington, D.C. or London or Abu Dhabi is different to the 8-fold path, the Bardak 8-fold path. The reality is that policies catch up with you. You may not, for example, H1N1, how are we going to respond to emergent diseases? Politicians, individuals, companies come up with disruptive change and disruptive regulation, disruptive technologies, and questions just bubble up from time to time. So in a sense, what we have to do is to try to pluck some order or put some order around that really quite stochastic, quite chaotic process. And our public health starting point is sort of laid down on our website, if you want to take a look in more depth, so haad.ae, is that we start off by looking at the disease burden. So we look at mortality data and morbidity data, and we look at that through a particular lens, which we call amenable health impact. So we look at the delta, disease by disease, between our burden of disease, epidemiology, mortality and morbidity, and global benchmarks. And then we filter that through the lens of, okay, well, that looks pretty bad, but is there anything we can do? So if we've got a big gap, and if there's something we can do, then that for us becomes a real priority. And we've listed 10 priorities. We refresh those 10 priority disease areas or disease intervention areas every year. And ultimately, this touches on how we made the decision to look at this primarily German but composite model. A decision is made within the health authority. So I've got my boss has got his boss within the health authority. And then we take our big recommendations, strategic recommendations, to the Executive Council of Abu Dhabi. So the decision is ultimately made for the Emirate of Abu Dhabi by this group of 12 senior government representatives. Now, the decision-making process, I would say, here is remarkably pragmatic and objective and evidence-based. And I think if decisions are, I'll give you one example. In 2006, we looked at our top 10 causes of cancer amongst women and amongst men. And it was clear that the third biggest cancer killer amongst women was cervical cancer. Now, without addressing the causes of this disease, which is primarily caused by human papillomavirus in the cervix, and what might be going on and might not be going on with adolescents and young adults in Abu Dhabi, we put the facts in front of the Executive Council, and the decision was made to fund at Abu Dhabi state level on the extended program of immunisations, Gardasil for girls at high school at the age of 17. There was a double consent process. We triple-checked with Sharia and other components within government to make sure this was the right thing to do. But an active decision was made on the basis of pragmatic data that showed that cervical cancer was killing lots of people, and we had a very, very effective intervention in Gardasil as a vaccine against the human papillomavirus, that this should be done. And then, you asked about were you screened whilst you weren't looking. Only those over the age of 18 in Abu Dhabi were screened. It's a little dark. I can't see if you might have been 18 in 2008 or not. The point is that adults, men and women over the age of 18, were screened, and the total uptake is 97%, and that's matched against family books and. So you may be one of the 3%, and possibly there are a cluster of you, strangely, on the fifth row. But the data is all in one place.
Okay, we have time for one more question. You're back there.
Thank you. Can I just ask? You gave a very polished and kind of.
Can you speak up?
Sorry, you gave a very polished presentation, and it's kind of obvious. You have so much information about the health system in Abu Dhabi. It seems very sophisticated. But can I just ask? Do you collect data on the levels of satisfaction amongst the users of the health system in Abu Dhabi? And could you tell us what kind of levels of satisfaction there are?
Yes, we do, and the answer is very mixed. If we take, for example, UAE national citizens, and we take a step through the journey from 2006 to create this new spick and span model, there were certain hospitals, so Sheikh Khalifa Hospital, for example, in Abu Dhabi, and Tawam Hospital in Al Ain, which were uniquely for UAE nationals. They're now accepting patients from other countries as well. In addition, there were certain expectations around international patient care. So if you needed to be flown to the Mayo Clinic or London, there were certain undertakings from the government, and step by step, we're looking to contain international patient care. It's a hemorrhage of value and trust from the system. Clearly, we need to make sure domestically the standards are as good, at least, as those abroad. But conceptually, that's what we're trying to do. So the answer is that yes, we are looking at satisfaction. We do that working with independent companies, so market research companies that take data, exit interview data for those being checking out of inpatient stays in hospital. We do random caller surveys as well. We also look at the satisfaction of physicians and facility owners and and insurance companies. And having driven 4 years of very, very sharp system reform, we are not uniquely popular. In fact, we are very unpopular with a lot of stakeholders. So I think everyone's hoping very much that we enter now a period of relative stability, so we allow some of these changes to bed down. I feel like I'm just talking very generally about what was actually quite a clear question. There is some data on the Health Authority website about satisfaction, and I would urge you to take a look at that. But we're aware that we're not as popular as we need to be.
Long and interesting evening to a close. Two things I want to do. One is, of course, to thank Dean Ricky Revesz for a fascinating presentation on cost-benefit analysis in the States, in the history of it. I'd like to thank Dr. Oliver Harrison for a fascinating presentation, especially for us, all of us living here in Abu Dhabi. You know, I'm very annoyed that we couldn't send a helicopter to come and fetch you when you were stuck at the other side of town, separated from us by dense and toxic traffic. But I did the cost-benefit on it, and I figured you wouldn't have liked the wrong decision to be made. So, no, but seriously, I'm very glad that you did finally manage to make it. I also like to thank Michael Livermore. He was willing to step into your shoes there, having glanced at your slides for half a minute, which I thought was very brave. But truly, it was a wonderful panel, and I'd like to thank you for that, and invite you to acknowledge our speakers.